Hello, and welcome to the IB Digest podcast from Takeda. I'm your host, Will Mountford, and today we're talking about the sequencing of biologic therapies in bio-naive patients with ulcerative colitis and Crohn's disease. Joining me to discuss ulcerative colitis treatment options is Dr. Rahul Nathwani. Dr. Nathwani, hello.
Hi, Will, and good afternoon or good evening to everyone, whichever part of the world you might be in. My name is Dr. Rahul Nathwani. I'm an American board certified gastroenterologist. I did my initial internal medicine and gastroenterology fellowships at the University of Southern California in Los Angeles, and I did an advanced therapeutic endoscopy year at the Thomas Jefferson University in Philadelphia. And I'm currently working as a consultant gastroenterologist with the Mediclinic group of hospitals. And I'm also an adjunct clinical associate professor of gastroenterology at the Mohammed bin Rashid University.
Okay. Well, if I could set out some patient conditions for you, and you can talk me through how you would respond and what the goals might be for treatment. If there was a bio-naive patient with moderate ulcerative colitis, that's a Mayo score of around 6 to 9, symptomatic with pancolitis or left-sided colitis, let's say moderate ulceration, they failed on conversion therapy with higher than normal lab findings. What would your treatment goals be in their case? What would the sequence strategy be to get to those goals, and any other considerations for how to approach their treatment? And what if they present with a higher Mayo score, 9 to 12, and can be classified as severe? Does any of that recommendation change? Hello, and welcome to the IB Digest podcast from Takeda. I'm your host, Will Mountford, and today we're talking about the sequencing of biologic therapies in bio-naive patients with ulcerative colitis and Crohn's disease. And now to consider things from the perspective of Crohn's disease, we go to Dr. Ahmed Al-Jazar. Dr. Al-Jazar, hello.
Hi.
For the people listening at home, could you tell us a bit about yourself, your research or practice, and then we'll get into some of the questions and considerations from there.
My name is Ahmed Jazar. I am a consultant gastroenterologist at Burjeel Day Surgery Center in Abu Dhabi. I have been here for about 10 years in Abu Dhabi in the UAE. Mainly, I was at a government hospital, now I'm at a private hospital, doing general gastroenterology with a concentration and a special interest in inflammatory bowel disease. I have a large practice with inflammatory bowel disease, a big portion of it. And it's very important to keep up to date regarding the therapeutic armamentariums that we have, since we have been having a lot of medications coming along with IBD, and to apply this to our patients for the best benefit for them. I have been doing few research projects with different pharmaceutical companies in order to collect some real world evidence regarding the newer therapies that have come along over the last year.
If a patient were to come to you who is bio-naive with moderate Crohn's disease, let's say that is symptomatic colonic or ileocolonic, moderate ulceration above normal laboratory findings but with no history of complications, what are the treatment goals for them? What are the treatment strategies and sequences that might be possible? And what are the best possible scenarios for this patient's ongoing recovery? Yeah, well, if we shift the goalpost then and change it from a moderate Crohn's disease patient to severe with a history of complications, what calculus has to shift with a severe patient versus moderate, and how does the sequence then change? What opportunities or challenges arise? Dr. Jazar, thank you so much for your time today.
Thank you.
Welcome everybody to another Grand Rounds, and we're really excited to be with you. I'm coming from Cleveland. Dr. Benjamin Cohen. I'm the co-section head for IBD, along with my colleague, Dr. Florian Reeder, who's usually here presenting or moderating with me for these sessions, but he's on a family vacation, so I'll try and keep things on track for everybody today. And we have two wonderful cases with, I think, a lot of really important teaching points. The first case will be presented by Dr. Al-Darmaki and will be a case of ulcerative colitis, and the second case will be a case of Crohn's presented by Dr. Abada. So with that, we want to jump right in, and we look forward to comments from our panelists as well. And again, our first case will be presented by Dr. Ahmed Al-Darmaki, who is a consultant gastroenterologist and IBD specialist at the Royal Hospital in Oman, and I will pass it over to him.
Hello, good evening, everybody. Thank you for the organizers for this opportunity, and it's time to discuss cases again on IBD Academy. My case will be about ulcerative colitis, and I try to choose a case which is not having primary sclerosing cholangitis like the last two times. So let's start straight away with the case. My patient is a 20-year-old female with ulcerative colitis. She is currently 20 years of age, but when she was diagnosed, she was 14 years of age in the pediatrics group. She was diagnosed initially in a private hospital, and the extent of her disease was involving the whole colon, pancreatitis, and this patient required prednisolone and mesalazine at diagnosis. She didn't have extraintestinal manifestations, and she was anemic with CRP of 25 and normal albumin. So if you saw this case currently now after the advancement in IBD therapy from 2018, what would be your approach? Would it be different, or you will be doing essentially the same? Maybe this is a question to our panelists.
Great. So I think this is, new diagnosis. This is something we come across all the time. So Professor Mogauer, maybe we can start with you, and hope you can comment on what the role is for 5-aminosalicylates in this situation, if there's any patient that you would put on 5-aminosalicylates if they've required steroids at their initial diagnosis, and then maybe what your approach is to the treatment-naive patient in terms of positioning advanced therapies.
Okay, thank you for the question. It's a pleasure again to be with all of you. And I think that conventional therapy will still have a great role and an important role in management of IBD. In such a case, which started by pancolitis and absence of extraintestinal manifestations, the most important thing to decide whether to start with conventional therapy or with more advanced therapy is to evaluate and stratify our patient according to the severity and according to prognostic factors. I think in such a case, I would really try to start with the conventional therapy. However, in the recent days, with the availability of more safe biologics and small molecules, maybe it would be a good opportunity to start using a biological therapy in such a case. If you mean positioning of therapy, I would rather evaluate further to find out which would be the most suitable line of therapy in the recent available great armamentarium, which will lead to better choices, better chances, better options, specifically in patients who have worse prognostic signs.
Great. So we have a lot more panels that join, so looking forward to a good discussion about this. Maybe Professor Cortes, can you tell us who is the patient that you would use the 5-aminosalicylate going forward? And then maybe you can tell us how you decide which advanced therapy, if you're going to move to an advanced therapy, that you would use in this situation. I don't know if Dr. Cortes is on, but if not, then maybe we can go to Dr. Ibada. Can you tell us a little bit about how you would approach positioning of advanced therapies for a moderate to severe patient who's treatment naive with pancolitis?
For this patient, she is have one of the criteria that she is young, less than 16, which means that she most probably will need an advanced therapy more than the usual one if she is older than this. But otherwise, she didn't have any something to prevent her from starting steroids and 5-SA. The maximum will be if you are using the oral as well as the rectal approach together with the prednisone, and then try to withdraw it fast. But I would share the opinion of Sharif that most probably she will need to have an advanced therapy. If she will need an advanced therapy, I think the most appropriate is the Vido to start with this patient. She more safe. She's as well as we don't have acute severe colitis. We are not in rush for rapid response. So I would go either to try to withdraw rapidly with the prednisone, and if no good response, I will shift right away to the Vido, or I start Vido right away.
Yeah, and I agree. I think that's a very appropriate algorithm to take. In our practice, patients are oftentimes wanting to try the 5-aminosalicylate when they first present. I'm a little skeptical that this patient with moderate to severe pancolitis is going to respond. But if in having that discussion with the patient, we just monitor very closely at the start and have a very low threshold to escalate therapy. So for example, if I'm having any difficulty decreasing their steroid doses, or if I see that their fecal calprotectin, for example, begins to go up as we lower the dose of the steroid, that's usually going to tell me that it's time to move to an advanced therapy. This is not somebody that you want to put on a 5-aminosalicylate and say, come back and see me in 3 or 4 months, because in that time you could have a significant escalation of their disease.
I'm really sorry, Dr. Cohen, I apologize.
Yes.
I was away. So basically, a patient with pancolitis, young, moderate to severe disease, is that what it is? And the
Correct.
question is, what do you treat with?
Correct. So how would you talk about, we've talked a little bit about when we would still use 5-aminosalicylates for this patient, but maybe you can talk about how you think about positioning the different agents, because now we have so many different options in terms of advanced therapies for these patients.
Well, I think Veto is an Entyvio is a great choice because of its safety and really positioning these agents. This is what I struggle with here in Lebanon. We're having the trouble with finding any biologic. That's one of our issues. But the ones that's available right now are mainly Remicade. We have adalimumab, Humira. We do have secukinumab. I'm not sure whether we can afford. Now, you can still buy it from other places. So, but in terms of science, I'm not sure. I would probably go with Entyvio at this point. And I still use Remicade, and I still use adalimumab for these patients, actually.
Yeah, I think you bring up important points also, that access is a big issue, and we have different access across different areas of the world. And in the United States, we struggle with insurance coverage for patients, and oftentimes that does dictate which therapy we may use first. So, and then of course the patient factors that may come into play with, there may be reasons why an infusion would be best, a self-injection, or even an oral therapy would be best. So it's, as we have more options, we have to consider all these other factors in making our decisions about which medications to use. So maybe we can move on with the case, and I think we'll still have some more discussions along positioning.
Excellent. So the case is just starting. So between 2018 till 2020, she was seen in another hospital where she actually was started on adalimumab as a first-line agent after requiring another dose of prednisolone. And after 4 months of adalimumab, she was primary non-responder, and she was switched to infliximab. With infliximab, she was optimized gradually up to 10 milligram per kilograms with no response. And repeated colonoscopy showed still moderate pancreatitis. So she came to us in 2020, and at that time, she was feeling better, almost asymptomatic, because she was on tapering course from prednisolone after traveling abroad and getting that as a treatment. And she was already initiated, after that, she was initiated on vedolizumab. And again, vedolizumab, around that time, we had an issue of availability. Not in all hospitals it was available. So she received 2 doses, and then for the third dose, it was not available for her in her original hospital, so she came to us for the third dose of vedolizumab. So just to go over her labs, and then we will open the discussion. The labs on Vido, she had a little bit of improvement in her anemia from 8.3 to 10, and improvement in platelets count from 700 to 430. Normal white cell count, CRP, came to normal, and her albumin was a little bit on the lower side of normal. She was asymptomatic within 6 months of starting vedolizumab. All right.
So this is an impressive response to vedolizumab after not responding to the anti-TNF medications. Maybe first I'll go to Professor Sharara, and then I can come to Professor Alamil. Professor Sharara, one, when you have a patient who's on anti-TNF, how do you assess for primary non-response? What's the role of therapeutic drug monitoring in that? And then in the patient who is a non-responder to TNF, what do you think about the other therapies following that?
Yeah, thank you, Ben. I think there are a couple of points in this case that also deserve attention. Clearly, when she was supposed to start treatment, she was still in adolescent. So I think also you have to think about what's approved in the pediatric age. I just recently had a patient in the US who reached out to me who would have been a perfect candidate for vedolizumab, but insurance didn't approve it because it's not approved in children. So really, you're stuck with the adalimumab and infliximab at this point, and clearly we all know that adalimumab is kind of the weakest drug in the treatment chain. So infliximab is naturally would have been the option if that's the only one that's available. Now, in my personal opinion, I think primary non-response, the role of TDM in primary non-response is not usually of that help. Not that helpful. Generally speaking, you're giving the patient the doses, you escalate the dose. They haven't responded after 3 induction doses, and the 4th dose, they haven't shown a response, neither inflammatory markers, clinically, etc. I don't think there's really much value in optimizing the dose any further in those patients. So I don't generally use TDM in primary non-response. I rely more on a clinical biochemical response and then make a decision accordingly. And shift out of class, generally with anti-TNFs if there's a primary non-response, especially if you're starting with infliximab from the get-go. Now, the other point I wanted to highlight is this is the typical patient, if you look at the Ibsen cohort, that has all the 4 factors that are predictive of a high risk for colectomy. Clearly, that was in the pre-biologic days, but still, that's just an indication of severity. And this is the kind of patient where you really, I think from the get-go, if they need glucocorticoid to induce their remission, they really need to go on a biologic and 5-ASA have no role in such a patient generally.
And for those patients who, when you're assessing clinically the primary non-response, how long do you typically give them before you say, you know what, the TNF inhibitor is not working and I need to move to something else?
Generally, I think the induction time and potentially the 4th dose after induction. But generally, I mean, I have patients who just didn't budge after the 2nd or 3rd dose and they're really worse. And I'm not going to expect a late catch up in those patients. If there's really zero response, I think that just is an indication which can be early from even the 2nd or 3rd dose of the drug.
Great. And Professor Alamil, there was I think Professor Schrar answered this in his response, but there was a question about why not check the trough levels of and antibodies for the anti-TNF medications. Is your approach similar to Professor Sharara? Where do you use therapeutic drug monitoring, if at all, with the TNF inhibitors?
Yeah, I agree with Professor Sharara. Generally speaking, in primary response, I would skip doing TDM and probably switch out of class rather than use a second anti-TNF if I have access to it. We generally do reactive TDM if a patient had shown early response to therapy and then lost response. That's where I use therapeutic drug monitoring in case optimization of the dose is a better approach than, for example, switching. But I agree. I would switch out of class without requesting TDM.
And how do you approach the positioning of the other drug classes after a primary non-response to a TNF inhibitor? Are there certain agents that you feel less confident about versus others?
Yeah, so when it comes to UC, I think, as Professor Sharara alluded to, adalimumab is not the best option. In this case, vedolizumab would have been a reasonable option. I think we saw recently the data from Love UC showing that patients who failed an anti-TNF, it was an investigator-initiated study, patients failed anti-TNF, and the response rate was more than 30% with vedolizumab. So that's very reassuring. Access notwithstanding, I would choose any other advanced therapy, taking into account, for example, that this is a female patient of childbearing age, who, for example, may want to have children in the near future, so I would exclude small molecules. Otherwise, I would probably go for any other advanced agent.
In the US, I would say that this has been the spot where we have been using a lot of the JAK inhibitors. Of course, in the US, we have different restrictions on JAK inhibitors, so that patients have to first not respond to or not tolerate a TNF inhibitor before we can prescribe a JAK inhibitor. But the network meta-analyses for their flaws do tend to show that this is where the JAK inhibitors would potentially be the best option. There may be a little bit less of a drop-off in the efficacy after the primary non-response or secondary loss of response to a TNF inhibitor. So I agree with you. We need to understand where the patient is in their life in terms of pregnancy, but number one is really getting them better. So oftentimes I encourage them to go on the JAK inhibitor here if they don't have any other risk factors. And I'm excluding the fact that this is an adolescent, so I'm not worrying about the pediatric approvals. I'll pretend that they've turned 18, so I can use whatever I want for them. But maybe Professor Aldermark, you can move on with the next part of the case, and then we'll have some more discussions.
Sure, excellent. Very nice discussion. And I would like just to add that in my setting, I sometimes switch from adalimumab to infliximab just because there is 2-3 weeks waiting time until the other molecules gets approved. So I might just ask for approval for vedolizumab, and patient has to wait for 3 weeks or 4 weeks. And meanwhile, I just give it a go with infliximab, and sometimes it works. So that might be done as well sometimes. If you don't have the luxury of having all medications available right on spot. So the bad thing about this patient that right after the last assessment, which showed completely improved clinical picture, she had an interruption in vedolizumab. And we had actually non-availability of the medication for 2 months, 1 to 2 months, and she skipped a dose. So she was actually seen with flare of symptoms, and she had stool studies in C. diff, which were repeated negative, but her CRP was 44, and her hemoglobin was 11.1. She also had a knee swelling, which with effusion in one knee. It was thought initially to be septic arthritis, but it was deemed not after being seen by the rheumatologist, and it was also diagnosed as autoimmune. So she received prednisolone for both her gut and her knees. Knees improved very fast, and also the gut symptoms improved. We resumed her vedolizumab after 4 weeks delay. There was this discussion whether we will re-induce or resume, but we didn't have a big stock of medicine, so we thought we'll just resume and see how it will go. But we will keep her on 4 weekly. So after 8 weeks of resumption of vedolizumab, she was still having inflammatory markers which were high. The CRP came down a little bit from 44 to 29. She was having high platelets, still anemic, but albumin was coming down. Now she is 29 albumin, and she was having 4 to 6 bowel movement per day with occasional blood. So the dose was optimized to 4 weekly, and after 4 weekly, after a few months on 4 weekly, her anemia was worsening, her platelets were going up, and her CRP remained high. Fecal calprotectin was 1,200, and her albumin was 25. She was having same number of bowel movements, but no blood at this stage. So before we go to the INTERPRET study, maybe we will just go over what the audience would think of this approach. Would they optimize to 4 weekly? Would they change to another class from the beginning, or what?
So maybe we can start with Professor Kotoubi, and then we can go to Professor Alawati. So Professor Kotoubi, how would you handle this situation? They initially responded. There was the unfortunate delay in therapy. Now you've resumed, and you're seeing a worsening of their labs after the restart of the vedolizumab.
Yeah, thank you so much. I'm going back a little bit. In my opinion, I mean, I would not choose Vido after anti-TNF. I don't think it is, it worked. Maybe in Crohn rather than in ulcerative colitis, but I don't know what, in Dr. Dammaki, that's what they have. Certainly, if the patient responded, you have 2 choices, either to increase to every 4 weeks or to change to another class of medication. It is not wrong to change, if this is what's available. That's what I'm hearing, what's available with Dr. Dammaki. So I would move to every 4 weeks, give it like a month or so, and see if it works or not. If it's not working, then I would switch to another class.
Dr. Alawati, would you any different thoughts, or would you do much the same thing? They may not be on. So maybe in the interest of time, Professor Aldermarki, you can maybe tell us about the INTERPRET, and then we can move on with the case.
So it is a good thing to go over this recent study, INTERPRET study, which is a randomized controlled trial of vedolizumab dose optimization, those patients who have early non-response. So essentially, this is randomizing patients after receiving the first 2 induction doses to either a standard dosing, patients will receive at 6 and then 8, or to an optimized dose. And this is again for patients who did not have an initial response at week 6. And the optimized dose was depending on the vedolizumab drug level to 600 milligrams IV at week 6, then 300 milligrams IV every 4 weeks, or to 600 milligrams IV every 4 weeks. And the result of that study showed no difference between the groups, no significantly important difference between the 3 groups. And it showed that if patients did not have an early response to vedolizumab, there is no much point of increasing the frequency to every 4 weeks rather than every 8 weeks. So the patient had a repeat colonoscopy, which again showed Mayo subscore of 2 colitis with a few inflammatory pseudopolyps in the transverse colon. And at that time, she was switched to ustekinumab. So ustekinumab was switched in February 2022. 3 months later, patient had a dramatic response. Asymptomatic, CRP less than 4, hemoglobin was still low, but albumin started improving. Now it's almost normal, 35. And the only change in the patient condition that she now started speaking up that she has depression, that her mood is not good. She had difficulty in coping at school. She has anxiety, and even she has some suicidal thoughts, which was a shocking thing because she is a patient who's in high school, comes always with her mom and dad. Her relationship with her mom seems to be very good, and they were too much connected. But on the other side, the patient had many issues which were covered during the quick clinic reviews. She also said that she had binge eating when she is anxious, and she is concerned about her gain of weight. And the patient herself, she was a smart kid who was reading a lot about psychiatric diagnoses. She was willing to see a psychiatrist, and she also had an idea about what she might be having. But her parents, they completely refused. They told her it's only because she is not keeping up with her prayers, and she is not really getting up at night. She is staying late at night, not getting up early in the morning. That's why she's having these problems. Otherwise, she doesn't have a problem at all. Her endoscopic examination showed Mayo endoscopic subscore of 0 with pseudopolyps. So she actually had a clinical and endoscopic response, complete remission with ustekinumab, and her histopathology examination showed inactive chronic colitis. So her labs on ustekinumab showed normalization of hemoglobin to 13.3, normalization of platelet count, CRP of less than 4, and albumin of 36. So after some discussion with her family, she agreed to see a psychiatrist in our hospital. Shall I proceed with the psychiatric evaluation? Was done almost 6 months after starting ustekinumab. She was at that time in grade 12, and the psychiatrist noted that she is an introvert, having low self-esteem, difficulty in making friends, and over-concerned about comments of others. She does not feel happy. She had death wishes, and she had 2 previous attempts of self-harm at the age of 12 and 14. Nobody knew about that. And she had also emotional eating and binge eating and induced vomiting features of bulimia. And the psychiatrist noted also that the patient thought she might be having a panic attack. So the patient was offering the psychiatrist diagnoses, panic attacks, bulimia, Asperger's syndrome, and depression. The mother, on the other side, denied persistent mood or anxiety symptoms of the patient. She thought that the patient exaggerated, and she thought that the regression in the school performance is due to ulcerative colitis and flares. And she also said that the patient sometimes blames the mother that she don't care about her, and everything now is because of the stress as she's in grade 12. The mother mentioned about a traumatic event at the age of 9, but she didn't disclose that, and said that the kid, the teenage, has a bullying at school. So the psychiatrist evaluation was that this is a personality issues with difficulty in coping, so she referred her to the local psychiatrist. Nothing was started, and no proper psychology evaluation also was done. A few months later, she graduated from high school. She moved to a college outside the village, so she's actually now away from her family. So she went by herself to see a psychiatrist, and she was diagnosed with depression. But the diagnosis which she was telling me in the clinic every time, that she has bipolar disorder. I didn't see that in the notes of the psychiatrist. So probably this patient was reading a lot about also the psychiatric conditions, that even she was trying to put a diagnosis in the mouth of her psychiatrist. She was started on depression medications, and then that was changed to another type of medication after having too much problems with sleep. She had also a few issues at the hostel in the college, where she had fights with some of her colleagues. She had one suicide attempt by taking 10 pills of promethazine given for her sleep. Eventually, the patient stopped the medication. That was probably after more than 6 months of taking the psychiatric medication. She stopped them as she was concerned about weight gain. In the clinic, we counseled her about weight, and we referred her to obesity clinic because she had gained significant amount of weight. She was seen at several times, and then she was started on GLP-1 medication, and then she came the following month, and she insisted that she would stop ustekinumab completely. She thinks that ustekinumab is the cause of her weight gain, and she does not want to continue with that. And if you see here a graph which we created, where she started actually with a BMI of less than 25 at her diagnosis. This is the times where she received corticosteroids, prednisolone, 3 times here. And then when she started with vedolizumab, her BMI was probably 23, and then she was gaining weight. The psychiatry issues were there before, but it was disclosed here, and she was started on fluoxetine for depression sometime later. Ustekinumab was started earlier in 2022, February. But see, she gained weight until she reached almost 50, BMI of 50. She was like a completely different person, and we need to do something about her weight gain.
So
yeah,
incredibly,
right.
Oh, go ahead.
So this is just to summarize the case. A 20-year-old female. She's currently in endoscopic remission on ustekinumab, failed anti-TNF before, failed vedolizumab secondary failure, obesity class 3 now, mood, personality issues, depression. She was started on GLP medications, and probably she will require bariatric surgery, and she is insisting to stop her medication which gave her the remission, ustekinumab.
So incredibly complicated patient. I think this really highlights how impactful behavioral health can be with IBD, and we see so many patients with concomitant anxiety, depression, stress, and this clearly Some of it is potentially from their IBD or just coexisting and then complicating our approaches to treatment. In the interest of time, maybe I can just ask you directly, Alder Maki, how did you address the patient's concerns that, for example, their ustekinumab is the cause of their weight gain, and how do we talk to patients about that to keep them on therapy?
So the patient was seen twice in the clinic, and she always comes with her parents. And her mom dominates the discussion all the time. But we try to explain that it's probably the binge eating, the behaviors of eating disorder which she might be having, but she was just thinking that since I started on these medications, all of them, I'm having a weight gain, which is going way beyond what she expected. So despite the discussion, despite telling her that trials, there's no trials which showed that the biologics by themselves are responsible for weight gain, although there is some association due to healing and improvement disease and improvement of well-being, but patient insisted, her parents also insisted that she will stop ustekinumab specifically. So I was between either to keep her without any medication or see whatever is available. So the two options were in front of me at that time were either to put her on JAK inhibitors, which might work, but I was worried because her BMI is 50. She is depressed. She doesn't move. She is really at high risk of VTEs. Or try another medication like anti-TNF, which failed before, but at least she is in complete remission now, and it might keep her disease from coming back. So it was a desperate move, but I thought this is probably the right thing to do. And fortunately, she agreed to start golimumab. And now she's for the last 3 months, she is doing fine. The only thing that she is actually admitted now with the febrile illness, and we thought she might be having dengue fever, which is happening now. We have many cases of dengue fever in Oman now.
Excuse me, what happened to her arthritis?
Pardon me?
What happened to her arthritis?
Arthritis, yes. So that was only an isolated one episode of arthritis, monoarthritis with effusion that completely improved after having a prednisolone course.
Well, I think this highlights the importance of shared decision making, and oftentimes our hand is forced, and we have to deviate from what we think may be the best path forward medically to work with the patient to what they're willing to do, despite all our efforts to educate them about what may be causing their weight gain and the impact of the behavioral health aspects of it. And if for those of us who are fortunate to work in centers where we have psychologists or psychiatrists on the team, that does make a big difference. But access to that kind of care is also limited probably across the world. So, really I commend you on all the efforts you've made with this patient. It's very difficult, especially in that adolescent age where the parents are very involved as well, because it's difficult to really know all the pieces that are going into what may be driving the depression for the patient. I know we have one more case and you have a couple of teaching slides, so maybe you can quickly go through the teaching slides and then we can move to the next case.
Sure, quick three slides. This study was demonstrating the high burden of obesity actually in IBD, and we are seeing probably more cases now. So from a retrospective evaluation of patients between 2010 to 2019, the prevalence and trends of obesity were studied. And from a big number of IBD patients, it was concluded that around 37.3% had obesity. So like almost 1 in 3 IBD patients are obese currently. And only 3.6 per 100 eligible patients were prescribed anti-obesity pharmacotherapy. And you can see here on the slide on the right side that the trend of obesity and hypertension have increased over time with those group of patients. What about bariatric surgeries? Bariatric surgeries, according to this review, is viable, effective, safe in weight loss management, and potentially it might result in improved outcome even on IBD management itself. And weight loss resulting from bariatric surgery can be beneficial in achieving remission, reducing disease activity, and decreasing medication dependence in patients with IBD. From a national registry-based cohort study of almost 71,000 patients, they found that there is an increased risk of GI obstruction from patients undergoing Roux-en-Y gastric bypass. And on the other hand, the sleeve gastrectomy was shown to be more safe and effective. So it is probably the right intervention for patients who require bariatric surgery in IBD population. What about the mental health risk in IBD youth? It was clearly shown also on this recent study from UK that patients with IBD have increased risk of sleep disturbances, depression, anxiety, even self-harm. And it is more in a group of patients who is like my patients who was diagnosed at the age of 14. This should be always assessed in the clinic. And the pattern was seen to be, this from a Canadian report on IBD outcomes, where it was shown that the pattern between anxiety and depression are almost the same in IBD patient. In a systematic review and meta-analysis of 77 studies, including over 30,000 patients, the pooled analysis was as twice as high in general population. And also, they found that close to 1 in 3 patients with IBD experienced elevated anxiety, and 1 in 4 patients experienced depression. So the rates of depression and anxiety are quite high. And in childhood, it's also even higher, around 20% of patients with IBD who are adolescents or children would have psychiatric disorder. So this is something which we need to screen in our clinic and look for all other challenges in patients living with IBD, like perceived stigma of IBD, going to work and school challenges with IBD, management of relationships and navigating social situations, and also very important to assess the body image issues with patients with IBD. This is the end of my presentation, and I leave the floor for our respected panel if there is any comments or discussion points.
Well, really a great case that really took us through many aspects of management of IBD, from the medical to the psychosocial, which have a huge impact. I think we are a little bit over time, so let's move to the second case, which is going to be presented by Professor Abada, who is a professor of internal medicine and gastroenterology at the Alexandria Faculty of Medicine in Egypt, and is also the president of ESCO. And he has a case of Crohn's disease to take us through.
Hello, everybody. Thank you for having me with you today. I will have today present a case of Crohn's disease. Maybe you are not seeing a lot, but I thought it is interesting to show you such case. This is a 40 years old male patient. He's a smoker, 1 pack a day, and he was previously healthy with no significant past medical history and no family history of GI diseases before. And he started to have persistent upper abdominal pain and a sort of heartburn and regurgitation that was partially responsive to PPI for 1 year. He insisted that he had no changes in his bowel habits, but we did for him a CT just to see what's happening there, because the CT showed a circumferential pyloric transmural thickening about 8 centimeters in length. The radiologist thought it could be inflammatory rather than neoplastic, and they asked for a upper endoscopy. So we did our endoscopy, and this is the esophagogastroduodenoscopy of this patient, and showed these large ulcers, star-like in the antrum as well as distal body, and shows some erosions here in the duodenum. And this is the picture of these ulcers. We took biopsies from these ulcers and came back as active Crohn's gastritis and non-specific duodenitis. We did colonoscopy for this patient because we thought it could be there as well, but the terminal ileum was up to terminal ileum normal mucosa. We took also biopsies, and it came back normal. Also, because of this patient, we take H. pylori stool antigen as in our lab investigation and came back negative. Also, because of this ulcer, we ordered for quantiferon and came back negative. Also asked for calprotectin, and calprotectin was also negative. So what next? We had a proximal Crohn's disease patient. Usually proximal Crohn's disease have 5% only of Crohn's disease, mostly 5 to 10%, but 95% of the time they have ileal as well as colonic involvement as well. Usually the duodenum more than gastric, more than esophageal, and isolated gastric Crohn's disease like ours is reported to be about 0.07%. Whether this is arising incidence or not, we don't know, but there is a slight male predominance for the isolated gastric Crohn's. For diagnosing gastric Crohn's, we have endoscopy and biopsy as we did, and also we need to exclude a few things. First, any cause for granuloma in the H. pylori, because the biopsy showed, if the biopsy showed granuloma, the pathologist want to exclude H. pylori, TB, as well as sarcoidosis. Also, if the patient is already a non-steroidal or not, Zolliger Ellison, vasculitis, as well as celiac, because sometimes celiac can present isolated ulcers in the duodenum. So I will show some pictures of what we can see in gastric Crohn's disease, and this is gastric case, another case having gastric Crohn's as well. But in this patient, multiple aphthoid ulcers in stomach as well as duodenum. But in the same patient, we did the colonoscopy and we showed the typical, and it wasn't difficult for us to diagnose that he has also Crohn's disease, both in the stomach and the terminal ileum, which is the commonest presentation. So, but other presentation for gastric, additional to what we had, already the large ulcers, we can have these serpiginous ulcers. This is another patient. Also, we have a very common and thought by many that it is a pathognomonic endoscopic sign for Crohn's disease of the stomach, which is the bamboo joint-like appearance shown in these two endoscopic pictures. Also, this is another picture for another patient for duodenal Crohn's, and it could be minimal. This patient that has already only aphthoid ulcers minimal epithelioid ulcer that could be missed if you are not looking carefully in your endoscope. Endoscopic signs, this is an echo 2017, showed the endoscopic pictures. This is in Korea. And as you can see, this 70% of patients, they have bamboo joint-like appearance, as you said, and patients already 56 only patients that they got the upper gastrointestinal involvement. This is another paper also on ECHO 2017 in Poland, and they showed the bamboo joint as well as others erosions, and this bamboo joint appearance was in half of the patients, and they said that it is a specific lesion for Crohn's disease as endoscopic marker, as they suggested. Also, upper GI CES score has been suggested for patients who already have Crohn's disease of upper GI, Crohn's, and they have the same ulcer size, ulcerated surface, affected surface, and narrowing. And this is the paper was in 2018 in ECHO as well. And you can see here that the score of those patients, mostly they are not that severe, and they have a sort of a score of 0 up to very few of them having a score of 3, as you can see, and in those patients. So what we can do for upper Crohn's.
So maybe we should pause here and just see how the panel would approach your case. So maybe we can first start with Professor Khatoubi. Can you tell us, when do you perform an EGD as part of your evaluation of Crohn's disease? Now, I know this patient had a CAT scan which showed abnormalities which triggered that, but is an upper endoscopy typically part of your workup for Crohn's disease? If not, when is it that you would do it?
Well, we are in a hospital where insurance is not, a factor that, do I need to get an approval? But in general, anybody with abdominal pain, and if we are investigating Crohn's disease in our hospital, we're doing both an upper endoscopy and a colonoscopy. We don't do only colonoscopy. I think upper is very important, and it can actually, most patients don't have a localized mainly pain, in the right lower or whenever, but generalized abdominal pain in Crohn, usually we do both.
Professor Sharara, is your approach the same in terms of when you perform the upper endoscopy as part of the workup? And then maybe you can also comment on how your treatment approach may differ in a patient who has upper GI involvement of their Crohn's.
Yeah, that's a really good question. I don't really have a really great sense of when to do an upper endoscopy in somebody who's coming with, the classic symptoms of diarrhea, elevated calprotectin pain. Generally speaking, if you look at the numbers, your yield is going to be low. Does that change treatment? That's one question. And then the second question is, how much further should you go? Should you do a capsule in everybody? Should you do an MRE in everybody? So again, it sort of expands difficulty. Generally speaking, if it's not going to change my treatment management, I don't necessarily include it unless there are referable symptoms or the MR shows something in the upper tract. And as far as treatment goes, I think we've discussed this on one of the cases previously. I think Philippe presented one with a gastric outlet obstruction. Generally, these are patients who have significant disease, not those who have few aphthy here and there in the upper tract, are sort of a difficult to treat patients and generally require a more aggressive strategy from the get-go. Though this patient has really remarkable endoscopic findings, and I think such a patient is definitely not going to do well with conventional treatment. And generally speaking, I would favor anti-TNFs in such patients, although potentially JAK inhibitors could be potentially also effective. And even ustekinumab. I mean, we talked about that patient, but I think vedolizumab would probably not be a strong option, in my opinion, in such a patient.
Yeah, my approach is very much similar to yours. I think our pediatric colleagues here, they tend to do the upper endoscopies as part of their evaluation, because upper GI Crohn's you tend to see a little bit more in the pediatric group. For the adult onset group, if the patient has upper GI symptoms, that's when I'm typically performing the upper endoscopy, or I always do get cross-sectional imaging as part of the evaluation of their Crohn's. And if I see inflammation in the upper GI tract, that will trigger me to do the scope. And agree, I think anti-TNF is where we have the best evidence for upper GI Crohn's, but this is an area where there is really limited strong studies. Obviously, the entry criteria for clinical trials are typically the colonoscopy, right? So they're not accounting for the upper GI Crohn's necessarily in that. So with that, we can pass it back to you, Professor Abada, for the rest of your presentation.
Okay, so for background, as we see, this is we have around maximum 10% of Crohn's disease that can have a sort of upper Crohn's disease, usually male more, and sometimes asymptomatic, but could present as non-healing ulcers on EGD, or sometimes concurrent with the lower GI symptoms, and then we search for them. And this is published by Mind Night, a very good work from them. And if you have a duodenal Crohn's disease, confirm the diagnosis. And if it is mild, it could go by PPI or sometimes budesonide, immunomodulators. But most probably, if they have a sort of moderate or severe disease, we can go for biologics. And rarely we can go for surgical option if there is a sort of obstructive symptoms and a bypass or resection. Also, the esophageal Crohn's, which is much rarer than the Crohn's of the duodenum and stomach, and they could be divided as the usual inflammatory type, restriction type, fistulizing type, and you can go treatment inflammatory, but PPI if it is mild, rule out HCV or CMV, but most probably you will go for anti-TNF, especially if it is fistulizing. If it's restrictioning, you can dilate as well as going with the biologic. So the therapy for upper Crohn's disease goes from PPI, steroids, immunomodulators, but mostly it is considered as a sort of risk stratified need to have a sort of biologics. Which biologics? Infliximab, adalimumab, sortilizumab, ustekinumab, or whatever. So we kept our patient now. This patient has an isolated upper GI disease, maybe of bad prognosis, as you can see, and this circumferential transmural pyloric thickening. He had travels a lot and have a sort of some difficulty with medications. He was actually from Libya coming to Egypt, and he can return back, and there he cannot have a sort of good access to medications. So for good biologics, which one we can use? Actually, we went through search, and we did find this out. Dr. Loftus and his group, having published in Gastro, they have out of 410 patients with Crohn's disease, 33 they treated with biologics, whether infliximab, adalimumab, and how a few of them have a multiple, even certolizumab. Only one of those patients have an isolated upper GI tract. That most of the 33 will have a sort of stomach Crohn's disease with the ileal or chronic disease. So, and this is the specific choice for first IBD therapy, and because of the traveler and convenience of the patient, we choose to go for it wasn't reported before at that time. This is 2020, and the patient has this ustekinumab, and he came back after 6 months for a re-evaluation, and this is his endoscopy picture, and this is the EGD, complete mucosal healing of after he received just the induction as well as 2 maintenance doses, and there is no evidence of any scar of had been present in his stomach as well as the duodenum, as you can see. And we published this in UEG week and has been accepted to be presented. This is a case of isolated gastric Crohn's disease, successfully managed with ustekinumab monotherapy and achieving complete mucosal healing in 6 months. And to the best of our knowledge, this was the first reported case for ustekinumab for isolated gastric Crohn's disease, achieving complete mucosal healing. And after that, we just in 2023, this was the largest nationwide approach in Spain, and they said what to be done in their upper Crohn's, and they actually found around 200 patients out of 22,000 patients over 10 years, and only 9 patients only have isolated upper Crohn's disease without the ileal or Crohn's disease or colonic, and they have inflammatory type, they have ulcers as well as the main endoscopic lesion in 42%, and very infrequently isolated duodenal location followed by what about treatment? Because this is the biologic era. Most of them has at that time using systemic steroid, thiopurines, but this is out of those patients, ustekinumab treatment. And as you can see, the red one was no response. Response is in yellow and remission in blue. This is after 14 weeks of treatment. And this is after 52 weeks of treatment. You can have a sort of in isolated, and you can have 2 columns, one of isolated upper Crohn's and E, which is extensive, which is both. And you can see that the ones who have isolated lesions have a better response than those who have combined upper and lower patients. And this was their conclusion, that upper involvement does not have an impact on immunosuppressive treatment requirement, but the extensive disease does, which means that if you have both upper and lower, it is much worse than if you have an upper alone. And rarely, of course, as all other Crohn's disease patients, they have a sort of risk of malignancy, but it is low. Back to our case, this case has been accepted by ECHO to be part of the rare and atypical IBD presentations, and actually asked for international call for any case similar to this case, which is isolated gastric Crohn's disease treated with biologics, to be published in a joint ECHO publications. And thank you.
Really some fantastic teaching slides around upper GI Crohn's, and I think you're highlighting and the effort by ECHO to accumulate cases really tells us about the knowledge gap we have when it comes to upper GI Crohn's. While the Spanish study shows a very low percentage, we don't know if that's just that patients aren't being diagnosed, and we're not picking up, or maybe there's more people with mild upper GI Crohn's that are not having endoscopies. But it's important that we understand better about how our treatments work in patients with this phenotype of disease. And I think your case with really amazing mucosal healing, you saw those were really some of the worst gastric ulcers I've seen from Crohn's disease, and then to have a complete healing with ustekinumab was really impressive. And probably most of our medications do work for these patients, so we're fortunate to have the options and to get them on effective therapies of some kind and treating them early. I think the most complicated cases I've seen of upper GI Crohn's really are the duodenal Crohn's, where they then stricture, and those are very complicated surgeries. I think the surgeries that our colorectal surgeons dread because none of the options are very good for them. Well, we've had great discussions. Unfortunately, we're over time, so it's always, we have so much education and so much discussion that an hour doesn't feel like enough. I want to turn it back to Professor Sharara to close us out on this great IBD Academy session. Tell us about what's coming up.
All right. Well, thank you, Ben. Thank you very much to the presenter, the beautiful cases. I know there are a lot of questions that are still probably people would like to ask, but we're short on time. And I think this is the forum that we'd like to sort of continue and spread across the region. It's great that we have now presenters from 7 or 8 countries across the region, and hopefully more to join. I want to wish everybody a great summer, and we'll meet again in September. Hopefully there was more ideas and more things to come in the future. I want to thank Ben and Flo, who's absent today, for always chairing these sessions in a really fantastic way. And last but not least, I would like to thank our sponsors, Takeda, for helping us. All right.
Thank you. Eid
Bye.
Mubarak.
Thank
Eid
you.
Mubarak,
Bye, everyone.
everyone.
Thank you
Thank
so much.
you.
Bye-bye.
Thank you.
Hello, and welcome to the IB Digest podcast from Takeda. I'm your host, Will Mountford, and today we're talking about the sequencing of biologic therapies in bio-naive patients with ulcerative colitis and Crohn's disease. Joining me to discuss ulcerative colitis treatment options is Dr. Rahul Nathwani. Dr. Nathwani, hello.
Hi, Will, and good afternoon or good evening to everyone, whichever part of the world you might be in. My name is Dr. Rahul Nathwani. I'm an American board-certified gastroenterologist. I did my initial internal medicine and gastroenterology fellowships at the University of Southern California in Los Angeles, and I did an advanced therapeutic endoscopy year at the Thomas Jefferson University in Philadelphia. And I'm currently working as a consultant gastroenterologist with the Mediclinic group of hospitals. And I'm also an adjunct clinical associate professor of gastroenterology at the Mohammed bin Rashid University.
Okay. Well, if I could set out some patient conditions for you, and you can talk me through how you would respond and what the goals might be for treatment. If there was a bio-naive patient with moderate ulcerative colitis, that's a Mayo score of around 6 to 9, symptomatic with pancolitis or left-sided colitis, let's say moderate ulceration, they failed on conversion therapy with higher than normal lab findings. What would your treatment goals be in their case? What would the sequence strategy be to get to those goals, and any other considerations for how to approach their treatment? And what if they present with a higher Mayo score, 9 to 12, and can be classified as severe? Does any of that recommendation change? Hello, and welcome to the IB Digest podcast from Takeda. I'm your host, Will Mountford, and today we're talking about the sequencing of biologic therapies in bio-naive patients with ulcerative colitis and Crohn's disease. And now to consider things from the perspective of Crohn's disease, we go to Dr. Ahmed Al-Jazar. Dr. Al-Jazar, hello.
Hi.
For the people listening at home, could you tell us a bit about yourself, your research or practice, and then we'll get into some of the questions and considerations from there.
My name is Ahmed Jazar. I am a consultant gastroenterologist at Burjeel Day Surgery Center in Abu Dhabi. I have been here for about 10 years in Abu Dhabi in the UAE. Mainly, I was at a government hospital, now I'm a private hospital, doing general gastroenterology with a concentration and a special interest in inflammatory bowel disease. I have a large practice with inflammatory bowel disease, a big portion of it. And it's very important to keep up to date regarding the therapeutic armamentariums that we have, since we have been having a lot of medications coming along with IBD, and to apply this to our patients for the best benefit for them. I have been doing few research projects with different pharmaceutical companies in order to collect some real world evidence regarding the newer therapies that have come along over the last year.
If a patient were to come to you who is bio-naive with moderate Crohn's disease, let's say that is symptomatic colonic or ileocolonic, moderate ulceration, above normal laboratory findings, but with no history of complications. What are the treatment goals for them? What are the treatment strategies and sequences that might be possible? And what are the best possible scenarios for this patient's ongoing recovery? Yeah, well, if we shift the goalpost then and change it from a moderate Crohn's disease patient to severe with a history of complications, what calculus has to shift with a severe patient versus moderate, and how does the sequence then change? What opportunities or challenges arise? Dr. Jazar, thank you so much for your time today.
Thank you.